Good evening, ladies and gentlemen. Good evening, dear colleagues. Great to see you at this webinar, which is provided by a educational platform, MedVoice, and I've been asked to present my experience with difficult airway case mixed that is based on my career-long experience. I've been an anesthesiologist since 1986. My name is Andrzej Warwinski. I have been practicing for the last 20 years in the United Kingdom, and most of these cases, well, all of these cases that I'm going to present today will be from my UK experience. As you probably know, during your career as an anesthesiologist, it's about a very, very small chance that you can actually come across a necessity to perform a front of the neck access. And on average, that happens about twice in the average career of an anesthesiologist working in the West. It happened to me more than once because I have an interest in difficult airway. I work as a consultant anesthetist at Torbay Hospital in the southwest of United Kingdom. I had a long-standing interest in difficult airway. I used to be a trust airway lead for a number of years, also a founder of a difficult airway course at Torbay Hospital for both doctors and for the anesthetic nurses and practitioners. We also at some point had a Torbay airway fiber optic course, which we now converted into something we call 3-in-1 course, where we have for participants a chance to practice nasal endoscopy, video laryngoscopy, and fiber optic endoscopy. We also set up a SWET course, Southwest Emergency Airway Training, where we teach our candidates how to perform front of the neck access. And I'm also a past president and founder of the Southwest Airway Management Society, which is a regional society that conveys the message of our national difficult airway society of the United Kingdom. Okay, so this is my case mix, and without any further ado, let's just move on to my cases. Okay, so the first case is something called Soto's syndrome, which we have published with some of my colleagues as far as 2001 in our national journal called Anesthesia. So what is Soto's syndrome? What it actually is? It's quite a very rare genetic disease. It's only about 150 cases in the whole of the world, and about half of them live in the southwest of Wales, where I worked at the time. It's a very rare genetic disease, various disorders of skeletal formation. They usually are mentally retarded. They have abnormal facial features, disproportionately body development, and have the anti-mongoloid eyes. Unlike Down syndrome, where they have mongoloid eyes, this one is an anti-mongoloid eyes, big, wide open eyes. It's also been labeled as cerebral gigantism syndrome. These are very tall people with large knobby skull, convex forehead. They usually have hypertelorism. They have a big tongue, a high arched Gothic palate, and large lower jaw with, as I said, impaired mental retardation. So this boy on the picture is only about 15. As you can see, he's a giant. Our case was a 13-year-old girl who was at 13, 165 centimeters in height and weight of 55 kilograms. She fractured her fibula about 5 hours before coming to the hospital, and also she has eaten 3 hours before the accident. And the surgeons, when they looked at it, the orthopedic surgeons, they said there is a vascular compromise of the foot. So this case needs to be taken to theatre pretty quickly. She was in a wheelchair as well because of her disability, because of her syndrome. She couldn't really walk unassisted. This is not as a previous one, this is not the actual patient picture. She, in fact, had a micrognathia, a small jaw, crowded teeth, definitely a high arched palate, short distance between chin and thyroid cartilage, so a short thyromental distance, Malampati, she doesn't really want to open the mouth wide enough for us to assess what the Malampati score would be. So we are in a bit of a tiger unknown territory with this girl. And 2 years ago, mom says she had a small procedure with absolutely no problems at all. She's mentally retarded. She's got a mental age of about 5-year-old. So it's very difficult to actually persuade her to do anything really. So what did we do? We got a crash trolley ready. We got a lot of instructions. We put a 4% Amitop cream on both hands to numb it. And with the mum distracting this girl, again, this is not the actual picture, we managed to get an IV access. And at that time, we decided to perform a very classic rapid sequence or crush induction using 300 milligrams of penton, succinylcholine, and intubated her with, surprisingly, grade 1 Quamclehane grade. We continued anesthesia, maintaining with sevoflurane. We used overall 75 micrograms of fentanyl and duncitron 4 milligrams and rectal diclofenac at the time. Surgeons done the manipulation of the tibia, put the plaster of Paris, job's done, nothing went wrong. But could it go wrong? And what are the other options? The other options, if she would completely disallow us to put any IV cannula, we could have done induction with a sevoflurane. But remember, she's got a full stomach, so she can start vomiting and regurgitating and whatnot with induction with sevoflurane. If she was more cooperative, less mentally retarded, we could have done it under regional anesthesia. But obviously, with her, a lack of cooperation on her part with mental retardation precluded us from doing regional anesthesia. So you left with a very little choices with this kind of case. And the best option, really, we thought at the time, was to perform rapid sequence induction and hope for the best. If I was doing it now, we're talking about 2001. If I was doing it now, these days, I would have definitely gone for using a video laryngoscope of whatever kind you have, just to maximize my chances of being successful. And in our trust, we made video laryngoscopy standard, and we use a video laryngoscope called McGrath. It's nice and portable, easy to use, and everyone in every theater will now have it available on demand. Also, you can use another video laryngoscopes. There are a variety of them. I'm not trying to advertise any of the companies, but lots of them are very, very good. Let's move on to case number 2. And this is a Lemierre syndrome. I'm not sure whether you heard of the Lemierre syndrome, but it's a combination of jugular vein thrombosis, septicemia, and the formation of metastasis foci of anaerobic infection elsewhere in the body. Okay, usually it's complication of tonsillogenic retropharyngeal abscess. But we interestingly had this syndrome combined with other syndrome, which I will talk about a little bit later. So it usually caused by Fusobacterium necrophorum, can be complication after the tooth extraction, and it had 90% mortality rate in the pre-antibiotic era. So it's pretty scary. It now returned due to lots of cases of antibiotic resistance. Our case was combined with Ludwig's angina, and Ludwig's angina, you've probably heard of, is a rapidly progressing pathology with severe swelling of the soft tissue of the submandibular region, may spread into the pharynx and retropharyngeal, sorry, not retinal, retropharyngeal space, and 70% is usually associated with dental abscesses. More often in men, it happens. And mortality before the antibiotic era was about 50%, and still pretty high. Still could be associated with 8% mortality rate. So again, this is a life-threatening condition. Microorganism, usually there's group A Staphylococcus or Streptococcus or Staphylococcus. could be Fusobacterium as well. In immunocompromised patients, there could be all sorts of bacteria, Pseudomonas, E. coli, Candida, Clostridium, all sorts. So you'll need to know after you've given broad spectrum antibiotics, which one is it to start antibiotic treatment pretty quickly. There's lots of predisposing factors, and usually it's poor oral hygiene, caries, tooth extraction in the past, diabetes, alcohol abuse, reduced immunity, there's poor nutrition, and of course there is smoking. So our case was a lady of a 67-year-old. Obviously, on the picture, it's not a lady; it's the young gentleman, but it's just there to illustrate for you what's the dental abscess can look like. This lady had a wisdom tooth removal 3 days ago. She had a lot of swelling, pain in the neck and jaw, swelling of the tongue, pain when swallowing. And more importantly, she's got a history of rheumatoid arthritis. As you can see, we are inducing this child here using a device called OptiFlow, which is the high flow oxygen device, providing oxygen not just at the high flow rate, but also it's warmed and humidified. And this is the device that I use all the time now for all my difficult airway cases when I'm expecting difficulty in securing the airway. So in our case, we had a severe tissue swelling in the submandibular area up to this jugular notch, severe limited extension and flexion of the neck, a very, very limited mouth opening to only about 15 millimeters, and a high Mallampati score of 3. When we asked this lady to perform upper lip biting test, she couldn't do that at all. And this is the test I wanted you to know a little bit more about. This is the test where you ask the participant, you ask your patient to bite the upper lip with their lower teeth, and you grade it by class 1, class 2, and class 3. So class 1 is where the lower teeth go above the vermilion border, above the top border of the upper lip. That will be no problem at all. Class 2 will have some difficulties, and if they cannot do that, that means the mobility of their jaw is very limited. And this test been validated against other tests like Mallampati, like paramental distance, many others. And this one single test was shown to be superior than many of the other tests for prediction of the difficult airway that we all know about. Okay, so coming to the examinations and investigations, we also performed the CT scan, which showed the computer tomography demonstrated a large collection displacing the oropharynx to the left. So you can see how it's been displaced to the left. We also had a CT scan of her lungs, and as you can see, she's got lung abscesses as well. So this is a widespread infection, not just into her neck, but also in her lungs. Here are the abscesses. Okay, so how did we do the case? What is our approach? We studied broad spectrum antibiotics. We used dexamethasone to try and reduce the swelling. And then we performed the nasendoscopy. We used the parapharyngeal and found the parapharyngeal and right arytenoid edema, but intact vocal cords. So we knew what was going to happen before we attempted any other manipulation. And as you can see on the right, nasendoscope, I'm using a sterile sheath. So rather than sending the nasendoscope for sterilization, it's this sterile sheath that can be put on, and then you can use it again without need to send it for sterilization. These days, they do exist as a single use option. We run the consultation with the thoracic surgeons, and they said, yep, there is no need to be worried about the thoracic involvement. You can do it in the center without the thoracic surgeons being present. So we decided to go for awake fibrobrotic intubation. We use glycopyrrolate, 200 micrograms. We use OptiFlow. which I have mentioned to you. As you can see here on this picture, the participant, this is the picture from the course, the participant is lying flat, and the anesthesiologist is standing behind the patient. This is not the approach that I would normally recommend these days, and particularly somebody who's got airway compromise. So these days I will sit patient in a semi-recumbent position about 45 degrees, and will be facing the patient. This way, it's easy for patient to breathe. You have a bit more rapport with the patient. It is a better technique to use. We use remifentanil for sedation, and we use 5% lidocaine mixed with 0.5% phenylephrine to both nostril. Usually I go for the right nostril because it's usually wider in about 70% cases, but you spray both nostril before you attempt to insert your fiber optic scope. And then you use 4% lidocaine in total of up to 9 milligrams per kilogram through a fiber optic scope in a spray as you go approach. Postoperatively, we've intubated successfully, and postoperatively, this patient been transferred to ICU for mechanical ventilation for 24 hours, reducing the swelling, dexamethasone, antibiotics, observation, extubation happened next day. If you really want to know how do I do awake fiber optic intubation, I refer you to my YouTube channel, which I'll show you the picture and the link later on, and you will see the full video and a short version of this video, of how to perform awake fiber optic intubation. What could be the other options? Traditional direct laryngoscopy. And obviously, you're running into risk of a can't intubate, can't oxygenate scenario if you will be unable to intubate that patient. So this is not a good option. A sleep fiber optic intubation could be performed. Obviously, again, you are at risk of the airway collapse while you're performing that. And unless you're a very slick intubator, a fiber optic intubator, then it could be used. But I will urge you to use this particular mask, which enables you to ventilate this patient, and through this flap, you can insert your fiber optic scope and the tube, rather the tube over it, while you are still ventilating the patient. This technique is performed really often, in particular in pediatric cases. Front of the neck access under local anesthesia could be performed, but you're running into a risk of infection. In her case, inability to lie flat, difficult anatomy as well, because as you saw on the CT scan, everything was moved to the right. So it could not be a particular easy option to perform, particularly in somebody with a distorted anatomy and a large size. Inhalation induction, you could run into risk of upper airway obstruction, and if you are to perform this technique, then there are better options like this 5-liter bag, which you will fill with sevoflurane, and you could use something called one single breath technique, which I've performed on a number of occasions. However, with a compromised airway, I usually I really discourage you to use the inhalational induction. Blind nasal intubation could be performed. However, you're running into a risk of failure, bleeding, and also performing a false passage, which I will speak about during one of the other cases. You could do cervical plexus block. However, still a risk of infection, anatomy, supine position, but that is another option that one could have used. There is a lot of literature about both Ludwig's angina and Lemierre syndrome, but the combination of Lemierre and Ludwig's angina, which we have published, is the only publication in the whole of literature. So this is why our case was quite interesting. We published it together with our maxillofacial surgeons in a Journal of Anesthesia and Critical Care open access, so you can freely access it. Fiber optic scopes, I just want to speak a little bit about it. Apart from a standard sort of traditional reusable fiber optic scopes that needs a lot of setting up, a lot of checking, and particularly in emergency situation, you may not have enough time to set it up. So Ambu now produces this single-use scope, and it's really sort of plug and play type of scope where you don't really need to do anything in terms of setting up. It's already in focus, so light is already done. The orientation mark is always at 12 o'clock, so you just literally plug it in, press the button, and it's ready to use. However, to perform fiber optic intubation, you need a lot of skills, and unless you, like me, which I do every Thursday, I do a case or two where I need to fiber optically intubate somebody. You lose skills, even if you've done some training. But this particular device called ORSIM, which is made in Australia and was invented by one of the anesthesiologists there. Allows you to play by putting the sort of fake fiber optic scopes through this unit, which is on the right, and then in the computer you'll have several different scenarios to practice. Bleeding tonsil, a tumor, a foreign body in the airway, and so on. We have this device, and we train our anesthetists how to manipulate the fiber optic scope in the different circumstances, different case scenarios. Let's move on to case number 3. This is blunt neck injury. So we were presented with a 19-year-old rugby player who was hit into the neck with an elbow of another player during the game. He's got sore throat, he cannot speak properly, he's got difficulty in breathing, and he's got massive neck swelling. He also, on examination, he's got hemoptysis, subcutaneous emphysema around his neck. Thyroid cartilage is not palpable due to edema. He's got quiet, hoarse voice, Glasgow Coma scale of 15, so he's fully awake, no neurology, and cervical spine is not involved. On the right is a picture of England's most broken man. And this is a rugby player called Johnny Wilkinson, who was a captain of the English team. And here you can see that he broken pretty much every bone of his body, but not his neck. No, he has his neck. Operation on the neck and shoulder. He's had fractured of a right shoulder as well. But what I'm saying is hasn't got a front of the neck injury like our patient had. So we also performed a scan on this patient, and we found lots of broken cartilages of their larynx, as you can see here. But this is nice and wide, although broken, but nice and wide. However, on another level, you can see a lot of a much narrowed airway here, which gave us a clue that this could be a very difficult person to intubate. So this airway is very narrowed on a particular level. Which particular level is difficult to say. So we decided to perform attempt the awake fiber optic intubation, but really attempt nasendoscopy to see what is there. Is it possible to perform awake fiber optic intubation? Because the fact that you will be able to observe, to see, to assess the anatomy doesn't mean that you'll be able to actually railroad the tube. So that's what happened. We attempted awake fiber optic intubation, but I quickly realized that if I proceed any further, this will be so-called cock in the bottle situation, where I will completely obstruct this patient, even with popping my fiber optic scope, which is quite thin, depending on which one you're using. It sort of ranges between 3 and 4.4 millimeters in diameter. But even that would have completely obstructed this particular patient. So we decided to go for plan B. Plan B was tracheostomy under local. He's breathing spontaneously. He's okay, although his anatomy is distorted, but he hasn't got a massive hematoma there. The surgeon was happy to perform this under local anesthesia. This case was 20 years ago. So we didn't have anything fancy like we have now, like TCI pumps, the propofol TCI infusion, or remifentanil wasn't available then. So we just use aliquots of midazolam in the total dose of 6 milligrams. We gave it 1 milligram at the time, and a total of 50 micrograms of fentanyl with glycopyrrolate, with me performing. Again, we didn't have OptiFlow, high flow nasal oxygen then, so we used CPAP via a circuit. And the surgeon performed a tracheostomy, a formal tracheostomy, not like your scalpel bougie tube, which is usually left for emergencies. He performed a formal tracheostomy and local, which took him about 20 minutes to perform, and that was successful. Patient desaturated a little bit at the point of insertion, but never below 90%. So the tube that we use, because you need to have an operation, tube that we used was something called J tube. After the J tube was inserted, which gives a great access for the surgeon, we induced him with propofol, maintained with sevoflurane, gave him more fentanyl, and then after the operation was finished, transferred him to intensive care unit. What was the damage? He had a longitudinal fracture of the thyroid cartilage, rupture of the mucous membranes along the upper edge of the vocal cords. The left muscular process of arytenoid cartilage was torn from the body of the cartilage, so lots of damage. But he had a good outcome, although despite all that, he had a bit of a voice change, but he's not an opera singer, he's a rugby player, so for him, this is a good outcome. Let's move on to case number 4. And as opposed to the previous one where we spoke about blunt neck injury, which doesn't look as bad as the open neck injury, this is what we had. This is from our local newspaper, Pensioners Cut Free in Crash Drama. So you can see there at the bottom of the screen that the pensioners, 2 pensioners, drove into a van which was offloading the goods. Not sure how it is in your countries, but the vans in my country look like this when they are offloading the goods. So this is the back door that opens and becoming like a platform from which the goods are handed to porters and people who are offloading the van, the lorry. But you can see the edge of it is almost as sharp as a scalpel. So when they drove into this van, this was opened. So this edge of the door went through the windscreen and through the neck of the driver's wife, an elderly wife. He saw it in last minute. It was dark. He saw it last minute. He then turned to the right, so avoided the injury himself. But his wife was hit by this door. And when they arrive, although there was lots of blood, but lots of bubbles going through this blood, and the saturation on face mask was 95%. So I thought, it looks gory, it looks dramatic, it looks like a lot of blood, but it's got to be an opening there. So I thought, has this? It was in A&E in casualty department, not in theater. We were called urgently to go there. So I thought there must be a hole. So I've asked for the endotracheal tube and basically inserted that into a hole that was made for me. So we called it a traumatic tracheostomy. And we published this at the as a poster and as an abstract at the Difficult Society meeting in 2011. So that was the easiest front of the neck access that I had to do, because the hole, as you can see, was performed by a lorry door for me, and all I had to do was to insert the endotracheal tube. So what I'm trying to say is that the open neck injury, although it looks dramatic, it looks awful, could actually be less dangerous than the blunt one. In her case, of course, none of the other structures were damaged. Her thyroid gland was more or less intact, and most of all, the major vessels were not intact. So we were very lucky, and she was very lucky. And so this is how it's ended. Then she had a repair and went to intensive care. Well, theatre first, repair, then to intensive care. Let's move on to my case number 5. This is the case of a rheumatoid arthritis with a 45-year-old male who is of a very small stature, but a very severe rheumatoid arthritis. He's only 44 kilograms. His BMI is very low, and he's on methotrexate and many other medications. He's having an elbow abscess to be done today. And 3 weeks ago, he had elbow transplant. But it appears that he probably got a chronic sepsis because these abscesses, probably because he's also immunocompromised, keep appearing in different parts of his body. So this one is in the elbow, and an anesthetist looks at him. He finds a very limited neck mobility. I'll show you how limited. A very limited mouth opening, although 2.5 centimeters, 25 millimeters is not that bad. It could be okay for LMA insertion, for example. But he's got temporomandibular joint involvement, so his mouth opening is limited by that. So anesthetist looks at the anesthetic chart of a previous case 3 months ago, 3 weeks ago, and he sees that his predecessor used laryngeal mask airway, total intravenous anesthesia, propofol mixed with fentanyl, all worked 3 weeks ago. He thinks, okay, I'll use the same plan if it works. This is the next sort of a neck mobility that we're talking about. Okay, so there's nothing, no movement from right to left, and this is the extent of movement. Flexion. This is not that case I'm talking about. It's a different patient of mine, and luckily he's got no teeth at all. So that was if with the teeth, his mouth opening would have been less than 1 centimeter. But this is the extent of a neck involvement in patients with a severe rheumatoid arthritis that you should be aware of, and some of them are fixed in the flexed position. So anesthetist decides to induce him with something that we call NODI, which is nasal oxygenation during induction, which is using a normal nasal specs with a dry, not humidified oxygen. This is in the era before we had Optiflow. You put it in the nose and you use it in pro-oxygenation. But when you take the mask off, while you're intubating, the oxygen is still going through. And the awake patient can easily tolerate 5 liters per minute, but the sleep patient, in the sleep patient, you can go up to maximum, which is 15 liters per minute. That's what this patient had on induction. LMA was inserted, but this anesthetist was not able to ventilate through a classic LMA. He took it out. He tried to ventilate with the mask, not possible. He used succinylcholine and 100 micrograms and milligrams. And then at this point, he asked for help. And I happened to be in next theater next door and about to anesthetize my patient. And I was asked to stop and come and help with this difficult case for my colleague. He asked for a trolley, a difficult airway trolley, to be there. And we attempted a laryngoscopy with a view of grade 4 of Comically Hale scale. So could not see anything with a size 4 blade. I just reminded you what they are. So we couldn't even identify an epiglottis on that patient. We took it out, tried to ventilate, unable to ventilate. Okay. We decided to add rocuronium for because we're talking several minutes later because succinylcholine worn off. We decided to use rocuronium because you can reverse it with Sugamadex, so it's probably a better choice. And then attempt video laryngoscopy. At the time, we were using something called AP Vena Advanced Video Laryngoscope. That was our standard video laryngoscope at the time, and it didn't fit into the mouth because in his case, quite chunky. He's only 44 kilograms. He's pediatric size. So we thought, okay, we have AirTrax, which is a channel type video laryngoscope. So we'll use pediatric AirTrack, small size, okay, with a camera that you can nicely see everything through. And still, we had a Comet Hain of 3. So we saw epiglottis, but not any laryngeal structures. What would you do next according to the Difficult Airway Society plan? Okay, you'll go back to plan B. So using either combination of a supraglottic airway device and bag mask ventilation. And if nothing happens, you will then, if you're not successful, then you will proceed to plan D, which will be your cricothyroidotomy. Okay, so this is where we are at this stage. We tried laryngoscopy, we failed. We tried mask supraglottic device, we failed. We tried mask ventilation, we are failing. So laryngeal mask, 3 different sizes, no ventilation. Forehand mask ventilation attempt, no ventilation. The peri-oxygenation is still happening. We had a timer on, now it's 11 minutes. We've been doing this for 11 minutes. SATs are still 93. And you think, okay, so they dropped from initial good SATs of anything between 97 to 100. And we're asking ourselves, it's been 11 minutes. We've not been able to intubate or ventilate. Is it time now? Do you wait for the SATs to drop further or not? We decided not. So we decided to do it now rather than wait for desaturation, because after 90, as you know, it happens really quickly. And who would like to do it? I said, it's your case. Would you like to do it? No, you're more experienced. And that's what I went for. I went for this device, thanks to this man. It's not the device that I've used, which I'm showing here and holding it. It's my college tutor called Richard Vanna. And Richard used to take us when I was an SHO in the 90s and in Gloucester Royal Hospital and into a mortuary. And we practiced using this device called QuickTrack. Richard has now invented his own little device for performing front of the neck access, which is what we're demonstrating. I hope that one day this will be on the market because it looks very promising and very interesting device for front of the neck access for easiness of insertion of a bougie. But what I've used is this. And this is called QuickTrack. It comes in 2 different versions, QuickTrack 1 and QuickTrack 2. And the difference is that in QuickTrack 2, you have a cuff as well. But this patient was so small that the one with the cuff is actually in bigger size. So I went for QuickTrack 1 instead of QuickTrack 2. And it was successful because I practiced it so many times on the cadavers when I was a junior trainee. This is not the device that we currently use, but basically it is a big trocar inside a large, about 4.5 millimeters diameter catheter with a little red stopper that prevents you from putting it too far. And I was successful, and it's got a cutting edge. So you don't need a scalpel to put it through. It's got a cutting edge and it goes in quite quickly. So it did work pretty nicely. And we were able to ventilate this patient, decided to wake him up, done the reversal with Sugamadex of our rocuronium, extubated him after 30 minutes, covered the wound, and decided to have a plan B for next day. To repeat surgery, but under interscalene block, which was performed by another colleague quite successfully. And this patient underwent his removal of the abscess, drainage of the abscess. ENT assessment was done, and interestingly, nothing specific was found there. So if this patient will need a future general anesthetic, we recommended that it should be done with a awake fiber optic intubation. This is case number 6, and as you can see, this is a huge neck with a massive swelling, the way you cannot even the chin is almost disappearing after this neck swelling. This could be due to postoperative bleeding with airway obstruction, particularly after operations on the neck involving thyroid and parathyroid glands. In 2021, this case happened before this, but in 2021, Association of Anesthetists together with DAS published these guidelines called Management of Hematoma After Thyroid Surgery. And they've done a systematic review, multidisciplinary consensus guidelines. They are with the thyroid surgeons and British Association of the ENT head and neck surgeons. They're very good guidelines, but even without these guidelines, we knew at the time what we should have done. And this is exactly what we've done, but it's now nicely presented in the ways of these guidelines that I would like to refer to, and then show you the actual video of how I've done it. So they say, okay, post-thyroidectomy surgery needs regular reviews, and they came up with this lovely mnemonics called DSATs, where D stands for difficulty in swallowing, discomfort. E is for AWS or news score, swelling of the neck, anxiety, tachypnea, difficulty breathing, and stridor. Okay, so you review it regularly, and if you have DSATs, you have these features, it just helps you to for early signs which needs urgent senior clinical review. So this could be done by nurses. So if your review reveals any or more of the above, you start oxygenate the patient, give them onsen oxygen at 15 liters per minute with a bag attached to it. Nurse it at 45 degrees head up, and then they refer to their way of managing the suspected hematoma and through the guidelines, which I will show you about. I'll show you in a minute. You would arrange an immediate senior surgical review, which will be at least a registrar level or consultant of head and neck kind of specialty. And if there's any signs of airway compromise, you need to evacuate the hematoma. So the buzzword is evacuate before you secure the airway. And this is the protocol that they came up with. You evaluate, oxygenate the patient using DSATs, you call for help, you then evacuate the hematoma, and then you intubate in this sequence. It may come as very counterintuitive to us as the anesthetist. So our gut feeling is always to secure the airway before allow the surgeon to do anything else. But on this occasion, the displacement of the airway, the trachea, could be so much that you won't be able to see anything. And after you've evacuated the hematoma, you will be. Okay, so this is the another mnemonic called SCOOP. Skin exposure, cut the sutures. So the cutters, if you're using staples, they need to be firm cutters next door to this patient, next to his bed. Open skin, open muscles, pack the wound, let the anesthetist intubate. Okay, hematoma could be superficial, so this could be this kind of scenario where you opened it and it's just there under the skin, and you evacuated the hematoma, piece of cake. But it could be deeper; it could be under the strap muscles. So you need to look under the strap muscles. Let's have a look how I've done it. So this young patient, obviously had a consent for this video, and we pre-oxygenated him in a semi-sitting position. It's a lot longer video. This is the shortened version just for you for this demonstration. So we then lower his head down a bit. We've induced him with propofol and rocuronium. You can see that the cricoid pressure is on, and I'm pre-oxygenating, and I'm letting the surgeon to open the wound first. This is my Max Fac surgeon opening the wound and letting the blood out. The patient wasn't in a very much of a respiratory distress, so wasn't compromised, but still had to evaluate. So we use this almost as a teaching sort of video to demonstrate to our trainees, to anesthetists, to ENT, Max Facs, head and neck surgeons of how to approach. And as you can see, the cricoid was still on all the time. And now I very easily intubated this patient, connected him to the circuit, and inflated the cuff, and we can now proceed to the rest of the surgery. So job's done. Everyone is happy. I also wanted to reiterate the message that if it was still difficult, one would have used, again, this is a few years ago, we didn't have video laryngoscopes. This day I would have used video laryngoscope, and also would have used a video laryngoscope together with my fiber optic scope, like a combined technique where, well, obviously you need two anesthetists there. One is helping to visualize the larynx, and another one basically using video laryngoscope as the bougie can railroad the tube with a bit more controlled fashion. So just remember about this technique that could have been used in the difficult situation like this. And let's finish it with a complicated nasal intubation. This is my case number 7, and I have a bonus case at the end for you. It's an apical dental abscess. The lady who's 39 years old has got slight metal retardation, recent tooth extraction, poor mouth opening. Last time she had, this is not her first abscess. Last time for the same abscess, she probably doesn't go to a dentist. She had a blind nasal intubation by one of the enthusiasts who was still in favor of doing those without any problems, and it went okay. So the second year resident, together with the consultant, decided to attempt just the same thing. They induced them with propofol, TCI, remifentanil, used rocuronium, mask ventilation without any problems. And nasal intubation should have really gone like this without any issues. Where I would normally use video laryngoscopes these days. This is a nice soft Portex north-facing nasal tube. I'd use a twisting maneuver, and it goes in nice and easy, usually using right nostril. In their occasion, they just went for a normal laryngoscope and obtained, with a direct laryngoscopy, and obtained Quammen-Klehane view of 3 with a blade size, mag blade size 3, through the right nostril, and it went straight into esophagus. So they couldn't do it, couldn't get the tube through the left one either. They decided to change the nostril, went through left, couldn't do it. Second attempt through the right nostril, could not pass the endotracheal tube at all. What happened? Now they're thinking, I need more senior help. So the senior anesthetist takes over. He tries to go through the right nostril, so through the original nostril, and realizes this tube is not appearing in the oropharynx. It goes somewhere, but he cannot see it in the nasopharynx. He makes the right conclusion that they made a submucosal insertion, so they made a false passage. It's bleeding a bit. So they decided to give up the nasal route, rightly so. They decided to use air track orally, could not insert it deep enough to visualize the structures. They've decided to use the video laryngoscope with a hyperregulated blade. They couldn't fit it into the mouth, because the one that they've used could be quite chunky. They put an LMA, and rightly so, and were able to ventilate. Great. So they can breathe out now and think what to do next. They decided to do a nasendoscopy using the nasendoscope through an LMA to see why they're having such difficulties. They couldn't really made any firm conclusions of why the difficulties occurring. So they called for help, and it happened to be me on that occasion, and I was miles away in eye theaters, and I arranged the replacement for my eyelid and came to help them in that theater, emergency theater it was. And what I've used is something called Aintree catheter, which has been invented a long time ago by group of anesthetists in Liverpool, hence the name. Aintree is the region of Liverpool. And they've described this technique of fiber optic intubation via, well, and in their case, via LMA with entry catheter. That's what it is. Entry catheter is basically a shorter version of a Cook exchange catheter with a side hole, but you can put it over the fiber optic scope, and you can put a rapid fit connectors, which you can see there on the screen, for connecting to a self-inflated bag like ambu bag, or for a jet ventilator like a VBM jet ventilator. So they suggested this kind of technique where you have 6 stages of insertion through an existing and working supraglottic device. Initially, they've used LMA because LMA was there available. Now we have we have second generation supraglottic devices. So I'll take you through. So after you've inserted the LMA or supraglottic device, which will be the first stage, the second stage will be to scope via, well, in my case, iGel. I use iGel as my preference because it's nice and straight. So you would put your entry catheter on top of your fiber optic scope. You'll have about 5 centimeters left of the scope sticking out of the entry catheter, which is enough for you to manipulate the tip. And then you'll go through the LMA, which will lead you straight into the larynx, and you'll have a lovely view. The second stage will be then take the scope out and ventilate via your entry catheter using ambu, because it comes, as I said, with this nice rapid fit connector. So at every stage, the beauty of this technique is at every stage you'll be able to reoxygenate your patient should have they desaturated, so you can reoxygenate them. So the second stage will be to remove the iGel and again reventilate via the entry catheter. So now in your airway you have entry catheter, which is 4.5 millimeters internal diameter, which is basically a small cuffless and the tracheal long and a tube that you can ventilate through. So all the time you're ventilating, reoxygenating your patient if required. Then you railroad your endotracheal tube, whatever tube you choose is your choice. And then you will remove your entry catheter out and ventilate via your endotracheal tube. Job's done. And this is exactly what I've done using this second generation device, iGel in my case. It could be other different devices that are available on the market, but I prefer this one. It's nice and easy and simple. It's got a second port. It's got an antibiotic block. It is flatter than a normal airway, so it is easier to insert in cases of a limited mouth opening. And this is just a bonus case for you if you present it with a ventilate the patient with a beard. All of you know that it's quite difficult to obtain the good seal. So the life hack here is to use a tegaderm or a 3M, fold it twice, cut the angle, cut the middle, and you will end up with a rhomboid shaped hole that you will put on the patient's face, asleep obviously, and then you'll have a perfect seal and you'll be able to ventilate this patient without any difficulties, apart from a little funny noise that will be happening while you're ventilating. So, okay, and you'll have a lovely seal. As you can see, we're using the bimanual technique where one anesthetist is holding the mask over the tegaderm and another one is squeezing the back. Okay. I thank you for your attention. It's been a pleasure talking to you and present to you my difficult airway case mix based on my career in anesthesiology. I also refer you to my YouTube channel, which bears my name, and I got about 72 videos in 3 different languages and a full description of awake fiber optic intubation and a shorter version of awake fiber optic intubation also different types of video laryngoscopy and the regional anesthesia techniques. I know that lots of you in Asia are attempting to pass the European exam in anesthesia and intensive care. And as I've been involved in this exam before, we have published this book recently in February called How to Pass the DAIC. The book is available in 3 different versions, paper version, Kindle version, and EPUB version that you can buy through different sources. We published it through Oxford University Press, so you can buy it through their website or through Amazon or many other, all the major bookshops are selling it. So I'm very pleased to present this book to you if your aim is to pass the European Diploma in Anesthesia and Intensive Care. It contains information about both parts, part 1, written part, and part 2, with obviously correct answers, explanations, and references. But thank you very much for your attention today, and I will be happy to answer any questions related to the cases I've presented later on, should you have any. Thank you so much.